Hey guys, welcome back to Job Studies Mad Fun. I am Dr. Angad and here we are at the final part of Pediatrics part 7. So let's start with gastrointestinal disorder guys. We'll start with a question guys and let's see how it goes. So a term neonate was noted to have excessive salivation. First think of the question, excessive salivation after birth immediately. On attempting to feed, baby vomited out everything. Within few minutes, baby developed respiratory distress and was shifted to the NICU. X-ray revealed the following. So what we found out guys, after birth, baby was feeding and was vomiting and excessive salivation was there. When you saw the X-ray guys, we placed an RT tube, nasogastric tube was there, and then you see there is coiling. Now just imagine if there is a huge pipe and you are putting a wire. If the wire is getting coiled, what can be the reason guys? There might be an obstruction or there might be a closure. There is no opening only to pass through. So such a condition in which immediately after birth, whenever there is excessive salivation, which means the saliva is not going inside, or whenever there is any feeds and the baby is not able to swallow it up, this is a condition of esophageal atresia. Esophageal atresia. Now, what are the associated anomalies guys with esophageal atresia? Esophageal atresia is tracheoesophageal fistula, TEF. What they will ask you guys is, in tracheoesophageal fistula, what is the most common type? The most common type of tracheoesophageal fistula is going to be type C. Now guys, what is there in type C? In type C, you will find out that there is proximal atresia and there is distal fistula. What I'm trying to say is, we'll talk more about this when we are talking about surgery, but just imagine if this is your esophagus and this is the trachea. Okay, basically what happens is there is a closure at this point. Okay, there will be a closure at this point, but then there is some communication at the distal part with the trachea. So because of this communication, next question is, why is there respiratory distress in this patients? Whenever there is a feed and there will be any consumption of this, or there, in any type, maybe in type B or type D, the food will go into the lungs, due to which there will be aspiration of feeds, thereby causing respiratory distress. So guys, this is esophageal atresia. What is the associated anomaly? Tracheoesophageal fistula. What you will find is that when you place a Ryle's tube, there will be coiling of Ryle's tube. Immediately after birth, there is going to be excessive salivation because it's not getting swallowed in, plus there will be regurgitation of feeds. Alright, this is your esophageal atresia. Next guys, a 26-year-old, that time it was immediately after birth, but right now it's a 26-year-old baby presented with complaints of repeated vomiting episodes. Okay, repeated vomiting episodes from the last 5 days. On examination, the following findings were noted. When you saw up the abdomen guys, the abdomen had an olive-like mass. The abdomen had olive-like mass, and usually you will not find out peristalsis, the movement which is there in the abdomen. You will not see peristalsis, but you found out there is visible peristalsis, that also from the left to the right side. That also found left to the right side. Then they are asking you, what is the diagnosis guys? This is idiopathic hypertrophic pyloric stenosis. Idiopathic hypertrophic pyloric stenosis, HPS also, which they call it. What they are going to ask you is, what muscle is involved in this condition? There are two muscles guys. One is going to be the longitudinal muscle and the circular muscle, but the one which is getting affected over here is your circular muscles. I want you guys to speak it out before I answer it out already. Okay? Chalo. Then they'll ask you guys, what is the investigation of choice in this condition? The investigation of choice over here in this condition is going to be ultrasound abdomen. Okay, what is going to be? It is going to be ultrasound abdomen. Next, they're going to ask you, which is a drug which is found out increased risk factor of IHPS, in idiopathic hypertrophic pyloric stenosis. That we have already discussed once guys. That is going to be your erythromycin. Erythromycin, right? If they'll ask you about the clinical features which you find in IHPS, that is, you will have non-bilious vomiting. What is the meaning of non-bilious vomiting, guys? Non-bilious means there is no bile. Remember, bile will go directly in the duodenum. Over here, we are having hypertrophic pyloric stenosis. So it is not able to go in the duodenum itself. Before that only it is getting regurgitated and vomited out, right? So there is non-bilious vomiting, very important. The differentiating factor only in this condition, like in duodenal atresia, another condition, right? There you will have bilious vomiting. Over here you have non-bilious vomiting. You will have olive-shaped mass. And you will have visible peristalsis moving from left to right. Now, an important thing which we have to always remember in IHPS is what are the electrolyte imbalance. It's very easy. Just apply logic. Now, just imagine there is a contracting force in your stomach due to which you are not able to, the digestive system is not able to flow normally. Now, because of which there is going to be vomiting. Now, you guys know in the stomach there is acid. And what is the acid, guys? It is going to be HCl. So, if HCl is there and that is getting vomited out, what will happen of the HCl inside? It is going to reduce. Correct? Next thing is, you also know that all the electrolytes such as sodium and potassium, they are also there. Now they will also get vomited out. That is also going to get reduced. Now another thing what happens is, now you see, because acid is going to get less in the body. So what will be the pH of the surrounding? It is going to be alkalotic. It is going to be alkalotic. This is so far what you need to know. So let's write this down. So what are the electrolyte imbalances? People will suffer from hypochloremic, hypokalemic, metabolic alkalosis. So far we discussed this only. HCl is getting less, so hypochloremic. Sodium and potassium are getting less, so then hypokalemic and hyponatremic also. And metabolic alkalosis because acid is going out. Now there is another important thing you need to know, that is paradoxical aciduria. See, if I'll give you a very chota and simple explanation, what happens is, and at the level of the kidney now, our sodium and potassium are getting out. Okay, so earlier first potassium is getting out. Now that we don't want, so then we will remove sodium. Now that also both are very important. So then what happens is, in the exchange earlier what happens is sodium and potassium are getting out of the body, and because we want to save the hydrogen. Why? Because hydrogen is acidic and already our environment is metabolic alkalotic. So we want to save the hydrogen. But because of saving the hydrogen, we are losing sodium and potassium. Now sodium and potassium, you guys know, it is very important electrolytes for the body. So even though we need to save hydrogen, unwantedly we have to throw out the hydrogen to take back sodium and potassium inside the body. That is why this condition is known as paradoxical aciduria. What I said was, because of the vomit, HCl is going out, acid is going out, environment inside is getting metabolic alkalotic. Now because the body is being very basic, we need more acid. So for getting more acid, there should be an exchange. We will take one H plus, remove one potassium, or take two H plus and remove two sodium. This process goes on. At one point when sodium and potassium is very less, right? So our body makes a decision of taking the sodium and potassium back. Now because sodium and potassium are coming back, due to which we have to throw back hydrogen. So we are again at level 1. That is why this is known as paradoxical aciduria. So remember what is the electrolyte imbalance. Now I hope it is easy. Hypochloremic, hypokalemic, metabolic alkalosis, and paradoxical aciduria. And also with that sodium is less, so hyponatremic as well. Cool. Always remember guys, the treatment of choice is surgery, and that is known as Remsted's pyloromyotomy, because there is hypertrophy, so we just cut the muscle. But before the surgery, we have to correct the electrolyte imbalance. If now you are using normal saline as the IV fluid of choice, you have to add potassium. If you're using Ringal lactate, it already has that much amount of potassium, so you can use Ringal lactate itself. Okay, so this is all about idiopathic hypertrophic pyloric stenosis. Next, guys, let's talk about the normal passage of the waste products. Meconium after birth usually will pass by around 48 hours, while as urine is going to pass by 24 hours. let's talk about some conditions which have delayed passage of meconium. That is going to be your anorectal malformations, Hirschsprung's disease, and congenital hypothyroidism. Anorectal malformations, Hirschsprung disease, and congenital hypothyroidism. Let's talk about Hirschsprung's disease. Guys, in Hirschsprung disease, whenever you think about this, always one thing should come in your mind, that is aganglionosis. Now, aganglionosis kya hai? The inhibitory fibers are absent, due to which there is continuous contraction but there is no relaxation. That's why you will notice the distal part of the colon over here is contracted, but the upper part will be dilated. Why? Because of aganglionosis, there is continuous contraction and there is no relaxation, absence of inhibitory fibers. Okay, so there is disordered paralysis, no relaxation, only contraction. That's why you will have a narrow rectum. Now, how do you diagnose aganglionosis? You have to do, this is an PYQ multiple times they have asked. It is going to be by rectal biopsy. Okay, management is just resect that part. Okay, remember guys, the most common site is going to be your rectum. Okay, this is about your Hirschsprung disease. Remember, if they'll ask you about the complaints, what are the complaints, guys? It is going to be delayed passage of meconium. Along with that, you will also have abdominal distension. Okay, delayed passage of meconium and abdominal distension. This is all about your Hirschsprung's disease. Next, guys, let's talk about very important topic, that is diarrhea. Guys, I told you about when we were talking about pneumonia, there are two most common causes of under 5 mortality rate in India. That is going to be one, diarrhea, and second is going to be pneumonia. Now guys, diarrhea can be divided into 3 parts based on the duration. If it is acute, anything which is less than 7 days, while as persistent and chronic is anything which is more than 14 days. Etiology of acute and persistent both are infectious, while as chronic is non-infectious causes. Like example is malabsorption. Okay, like example is malabsorption. Now, how at times you might get confused which one causes infection? Is it persistent or is it chronic? Remember, P for persistent, P for pus. P for persistent, P for pus. So like that you will remember that P for pus. So that you will remember persistent is related to infectious. Both persistent and chronic is determined by duration is more than 14 days. But persistent is because pus is because of an infection and chronic is because of any malabsorptive disorder. Okay, guys, when you define diarrhea, now normally you talk about the duration, the frequency, which is more than 3. But more important than that, a recent change has come is the recent change with consistency of the stool is a much more important factor to talk about diarrhea rather than the frequency, which is more than 3 times. Okay, if you will ask in pediatric cases what is the most common cause, it is going to be viral. And which viral, guys? Rotavirus. Okay, which virus is going to be rotavirus. Okay, if you talk about the most common bacteria, that is going to be your favorite E. coli. And what type of E. coli, guys? Microbiology, it is going to be enterotoxigenic E. coli. Enterotoxigenic E. coli. And this is again a most common cause for traveler's diarrhea. Another PYQ. Now guys, if they ask you what is the most common cause of diarrhea, which is loose stool but with blood. Now what is this condition, guys, called? This is known as dysentery. And guys, the most common cause is going to be your Shigella flexneri. Okay, Shigella flexneri is the most common cause of dysentery, whereas the most common bacterial cause of diarrhea is going to be Escherichia coli, ETEC, enterotoxigenic E. coli. Most common overall cause is viral, that is rotavirus. Now guys, let's talk about the important management of rotaviral diarrhea, which is very common, okay, especially at this time right now in the month of the monsoon seasons. Now guys, if you talk about the management of rotaviral, it is we are based on dehydration. We have to see the dehydration which is having to which the child is suffering from. You are going to divide dehydration into 3 parts, not mild, moderate, severe. It is going to be no dehydration, some dehydration, severe dehydration. Say again, no dehydration, some dehydration and severe dehydration. Okay, what are the features, guys? In no dehydration, the baby is going to be alert and active, AA, alert and active. In some dehydration, just imagine yourself, okay, if you're little thirst, if you have little dehydration, okay, what you will be thirsty, thirst will be there, and along with that you will be irritable. You'll also be irritable. Thirsty will be there again, thirst will be there, and along with that irritable child. Okay, irritable and thirsty. Severe dehydration, the baby will be lethargic. Very important. You remember when we were talking about danger signs in pneumonia also, amongst the 4, which were the, chalo repeat, let's see. One was lethargy, lack of appetite, which is feeding and drinking was not there, convulsions were there. Another C was cyanosis. So over here also, severe dehydration, anytime if there is letharginess, that is severe, thirst is there, or if the child is irritable, that is going to be your some dehydration. And if active and alert, that is no dehydration. Now then you will do the skin pinch test. Skin pinch test in a no dehydration is going to be less than 1 second. In some dehydration, it is going to be less than 2 seconds. And in severe dehydration, it is going to be very slow, that is going to be more than 2 seconds. Very slow, slow, and less than 1 is obviously fast. Okay, now guys, we are going to talk about the plan, what we have to do. So in a case of no dehydration, but the patient had diarrhea, what are you going to do? Jitna pani nikla, utna pani de do. Means you have to give the ongoing loss replenish the ongoing loss, that is it. And how do you do that? Either you give around 100 ml of ORS or 200 ml of ORS. And how do you check that is 10 to 20 ml per kg. Remember, this is known as plan A. So for no dehydration, you're going to give plan A, that is 100 to 200 ml of ORS, which is 10 to 20 ml per kg based on the child. If he did 4 times, and if it is 100 ml you're giving, you'll give 400. If he did 5 times, you'll give 500. That is plan A for no dehydration. Now, whenever we are going to talk further, now first no dehydration, then is some, and then is severe. You are going to add the plans. Plan A will go for everything. Then after that, plan B. Then for the last one, plan A, B and C will be there. It's not directly plan B, something different. You have to add plan A. Okay. Now in second condition, which is some dehydration, what is the management, guys? There are 3 steps. You have to rehydrate the patient with a speed in the, IV fluids will be 75 ml per kilogram in the first 4 hours. You have to rehydrate in the patient for some dehydration 75 ml per kilogram in the first 4 hours. Then you have to replenish the ongoing loss, same which we discussed, 100 to 200 ml per loose stool. Then a very important thing is we have to give now the maintenance of daily fluid requirement. How do you calculate this? Third, and see, 3 things we did. One is replenish, then ongoing loss, and third is daily fluid which is required, that we have to do. You have to calculate that with a formula which is known as Holiday-Segar formula. That formula is known as Holiday-Segar formula. There are 3 steps for Holiday-Segar formula. First 10 kgs. If a child is in the first 10 kg, 1, 2, 3, 4, 5, with every kg you will add 100 ml. For example, if the baby is 7 kg, how much you will give? 700 ml. If it is 9 kg, you will give 900 ml. And if it is 10 kg, you will give 1000 ml. Itna clear hai? Done. After that, from 11 kg to 20 kg, for each 1 kg weight gain, you are going to give 50 ml. For example, if a child is 15 kgs, now I already know in the first 10 kgs how much I am going to give, that is 1000 ml. Hana? For the first 10 which we talked about, bacha will be 5 kgs. So 5 into what I said you was, ki 5 you have to give 50. Hana? 50 for each 1 kg you will give 50 50 ml. So that is equal to 1000 plus 250, that is going to be 1250 ml. That is going to be the daily requirement. That is what you have to give. So using the same logic, first 10 kg was 1000 ml. Then the next 10 I told you have to add 50 ml for each kg. So for 20 kg guys, how much it will be? It will be 1500 ml. Correct? Now after this, after every, which is if it is 21, 22, 23, for each 1 kg weight gain, you are going to give 20 ml. Clear? For the first 10, each 1 kg was 100. For the next 11 to 20, each 1 kg was 50, and from 21 onwards, each 1 kg is going to be 20. For 11 to 20, each is going to be 50, and from 21 onwards, it is going to be 20 ml per kg. I have written it over here. First 10 kgs 100 ml. Next 10 to 20 kgs is going to be add 50 ml per kg, and every 20 kg you'll have add 20 ml per kg. Simple. These three things you have to do over here: rehydration at 75 ml in the first 4 hours, ongoing loss treatment, and then using the Holiday-Segar formula, you are going to calculate the maintenance of daily fluid. Okay. Now in case of severe dehydration, what you guys have to do is, guys, 3 same steps so you have to go. First is ORS. This time you're going to give around 200 ml because obviously you need more. Then is going to be ongoing loss treatment, which we just now discussed. Rehydration, but this time the rehydration is going to be at 100 ml per kg in the first 4 hours. Now this 100 ml is further divided into 30 ml and 70 ml based on how old the child is. If the child is less than 1 kg, 30 ml per kg should be given in the first 1 hour, followed by 70 ml per kg should be given in the next 5 hours. After, if the child is more than 1 year, he can tolerate it much better. The first 30 ml per kg should be given in half, divided by half, 30 minutes. And the next 70 ml per kg for a child who is more than 1 year, again divide by half, it will be 2.5 hours. There we discussed was 75 ml per kg in some dehydration in the 4 hours. Over here we're talking about 100 ml because it is more severe. This is all about maintenance of rotaviral diarrhea. Plan A, B, C. Plan A only ongoing loss. Plan B may you will also add 2 more things which will be there. That is going to be rehydration 75 ml 4 kgs, then using the Holiday-Segar formula, daily dose calculation. Severe dehydration में सारा वही ऐड करना है, पर इस बार the rehydration will be at 100 ml per kg in the next 4 hours. We are dividing it into 2 parts, 30 ml and 70 ml. Based on age, then we have to do the per hourly how much you have to do. Simple. Along with this, in the diarrheal management, guys, we are also going to give zinc. We talked about zinc already. Zinc is very good with the help of GI epithelialization. How long are you going to give it? You're going to give it for 14 days. If the child is less than 6 months, you're going to give 10 milligram. If the child is more than 6 months, you're going to give 20 milligram. If there is dysentery, which is the most common cause was Shigella dysentery, right? What are you going to give? You're going to give 3rd generation cephalosporins. Talking about ORS, what constitutes is very important. You guys need to know. WHO ORS is actually low osmolar, okay? 245 milliosmoles. Now they will ask you what are the constants. Guys, in glucose will be around 75, sodium also 75, potassium is 20, chloride is 65, and citrate is 10. Now why do you think glucose and sodium have 75? If anyone is strong in biochemistry, please comment it below and help others as well. It is a very good thing. Okay, why do you think? Because this is related to something relating to some transport and all. So enough hints. Now you guys have to answer that. Okay. So these are the ORS ka formula, and that question can come. So make sure you try to attempt the question. Okay. Next, guys, let's talk about renal disorders. In renal disorders, we'll talk about UTI, urinary tract infection. UTI is much more common in female than in male. Why? Because females have short urethra. Correct? What is the most common cause, guys? It is going to be E. coli, Escherichia coli. Talking about the features, you have 2 types of urinary tract infection, upper and lower. Now, upper and lower are based on, they are defined on 3 things, okay? And these are the definition which you need to know. Fever. In upper urinary tract infection, it is going to be high grade. While in lower, it is going to be lower grade. The pain in upper is usually related to the kidney, pyelonephritis. Upper UTI is known as pyelonephritis, right? So, it is also known as pyelonephritis. Okay, lower UTI is also known as cystitis. Fever is going to be high grade, lower UTI is going to be low grade. In upper UTIs, the pain is going to be in the loin regions, while in the lower UTI it is cystitis, urinary bladder, it is going to be in the suprapubic region. Talking about urinary frequency, in upper UTI, the patient will be suffering from oligouria, while as in lower UTI, the patient will be suffering from increase in frequency, polyuria. Okay? How do you diagnose UTI? One is based on the three factors: fever, where the pain is, and what type of urinary frequency. Along with that, we have to talk about urine culture positivity. Now, whenever we talked about the presence of bacteria in urine culture, we'll talk about three methods. One is the midstream clean catch. Other is urethral catheterization से हमने sample लिया, या फिर suprapubic aspiration. Remember, in midstream clean catch, how much will be the significant bacteria का like diagnostic feature is if it is anything more than 10 to the power 5 colony forming units per ml. 10 to power CFU stands for colony forming units. Okay. Urethral catheterization, anything which is more than 10 to power anything which is more than 5 into 10 to power 4. Okay. Suprapubic aspiration, which will be there, any amount of bacteria, even one is enough for diagnosis because it is a sterile area. Okay. Midstream catch, urethral catheterization, and suprapubic aspiration. Talking about asymptomatic bacteriuria, remember guys, usually no therapy is required, but only whenever there is urine culture positivity along with no features, that is only you have to do that in case of asymptomatic bacteriuria in pregnancy, because at that conditions preterm delivery and such complications are common. If I show you this both investigations and they'll ask you what is this diagnosis guys, what is the investigation used? This investigation is over here, both of this is known as micturating cystourethrogram, or also known as voiding cystourethrogram. Okay, bladder and the urethra को पूरा check कर रहा है, and micturating and voiding is basically passing urine, है ना? If they ask you, whenever you have a child who is having recurrent urinary tract infection, always suspect for a renal anomaly. That is one thing. Now, if they show you this this image, they pass the dye and they have seen over here this image, same thing like that. What is your diagnosis, guys? You see the fluid, instead of going down, it is going from bladder up to backside. This is known as vesico-urethral reflux. Remember, guys, the most common anomaly in urinary tract infection is going to be your vesico-urethral reflux. Okay. If the same question, recurrent urinary tract infections in male, and then you see this keyhole deformity, keyhole sign, then your diagnosis is going to be posterior urethral valve, seen in males. Okay. Now guys, let's talk about nephrotic syndrome. Guys, in nephrotic syndrome, they will ask you what are the clinical features. You will have massive proteinuria. Too much protein is going. Now, because albumin is a protein and it is also going, so then you will have hypoalbuminemia. Now, you guys know that albumin, we discussed this already, is responsible for blood colloidal osmotic pressure. Now, this blood colloidal osmotic pressure is responsible for keeping the stuff inside the blood vessel. Now, albumin is not there, so there is no osmotic pressure like that, so everything will go out. That is why the patient will suffer from generalized edema. And our body responses to increase the lipid, so you will have hyperlipidemia, massive proteinuria, hypoalbuminemia, generalized edema, and hyperlipidemia. Like this, you will not forget this condition now. Okay. If they'll ask you what is the most common type, guys, that is going to be your minimal change disease. Okay, it is going to be your minimal change disease. If they'll ask you what is the pathology, guys, it is loss of food processes of the podocyte. Now, because of this loss of the food process of podocyte, negative charge is lost and there is nothing to repel the protein and the protein will come out. They will ask you, how do you define nephrotic syndrome? Normally, guys, there is less than 4 milligram per meter square per hour of protein in the urine. But in case of massive proteinuria, it will be around 10 times more, that is 40 milligram per meter square per hour. In urine dipstick test, you will have 3+ or 4+ sign. Okay. Let us talk about the differences between minimal chain disease and significant chain disease. Significant chain disease, also known as focal segmental glomerulosclerosis. Okay, focal segmental glomerulosclerosis. First of all, you'll ask about the age. Minimal chain disease is usually seen by 2 to 6 years of age, while significant chain disease is usually seen in adults. There is no hematuria or hypertension in minimal chain disease, but there is significance in significant chain disease, so it is present. Renal function test is normal in minimal chain disease, while it is abnormal in case of significant chain disease. Response to steroid, guys, is excellent in minimal chain disease, while it is resistant in case of focal segmental glomerulosclerosis. Okay. Now, guys, we're done with minimal chain disease and significant chain disease. Now let's talk about glomerulonephritis. Now, guys, in the features of glomerulonephritis, hematuria is a hallmark. Okay. What are the features of the hematuria? Remember, guys, it is going to be a cola color urine. Microscopically, you will find dysmorphic casts, and you will have RBC casts. RBC cast and dysmorphic cast. Along with that, other features will be this time mild proteinuria, hypertension will be there, edema will be there, periorbital or facial edema, and oligouria will be there because now it's in the kidney side. Okay? What is the most common cause, guys? The most common cause of glomerulonephritis is post-streptococcal glomerulonephritis. What is the most common organism? That is going to be your group A beta hemolytic streptococcal infection. How it is happening? If a person had a sore throat, which is pharyngitis, usually Psgn happens after 1 to 2 weeks of a pharyngitis. But because of the same organism, if it is causing a skin infection, that is your pyoderma, 3 to 6 weeks after the pyoderma, patient can suffer from Psgn. This is a type 3 hypersensitivity reaction. Type 3 hypersensitivity reaction means it is immune complex mediated. Because of these immune complexes get gathered in the kidney, and that is why there is rupture, there is damage. That's why you are suffering from a hallmark is cola colored hematuria, which is also you'll also find microscopically RBC cast and dysmorphic casts. So let us talk about the difference between post-streptococcal glomerulonephritis and IgA nephropathy. IgA nephropathy, guys, is also known as Berger's disease. IgA nephropathy is also known as Berger's disease. Let's talk about the presentation, guys. Psgn is usually having single episode, one episode, and it resolves. IgA nephropathy has multiple episodes. Psgn is usually seen in school-going children, while as Berger's disease is usually seen in adolescents or adults. The hematuria is found after, just now I discussed about, if there is streptococcal, like URTI means upper respiratory tract infection, pharyngitis. So you will get that after 1 to 2 weeks. But guys, in Berger's disease, you will get it in 1 to 3 days, very fast. So defining feature. Now, as I told you, in post-streptococcal glomerulonephritis, it is a type 3 hypersensitive, so it is immune complexes. Now, immune complexes, when they're increasing, they are going to diminish the complement pathways, because of which serum C3 levels are going to reduce. Serum C3 levels are going to reduce. Now, another detection for streptococcus is antostreptin lysine O. That is going to increase. ASO levels are going to increase. And in the skin, you will have anti-DNase B. That is also going to increase. What is your management, guys, in Psgn? Conservative. Whatever, if fever, give paracetamol and stuff like that. Symptomatic management. Okay? Remember, guys, now is Berger's a type 3 or something complement reaction? No. So that is why C3 levels are going to be normal. There is no relation to ASO levels in this, and there is no relation to anti-DNase B in this. So that is how you distinguish Psgn and Berger's disease, guys. Another topic, let's talk about renal vessel vasculitis. That is going to be your Hinox-Schulden purpura. Remember, guys, when we were talking about Kawasaki disease, once again, this will be better, yeah. When we were talking about Kawasaki disease, Kawasaki was a medium vessel vasculitis. But over here, renal henoxylin purpura is going to be a small vessel vasculitis. Okay, how do you remember what are the features of henoxylin purpura? That is what they ask. Remember it HSP, henoxylin purpura. Mnemonic is also HSP. H stands for hematuria. S stands for skin changes. That is going to be palpable purpura. Now purpuras are usually because of thrombocytopenia, but over here very important, it is non-thrombocytopenic purpura. Non-thrombocytopenic purpura. And P stands for pain. That is going to be joint pain and abdominal pain. Joint pain and abdominal pain. That is your renal vesicle vasculitis. That is your henoxylin purpura. Final chapter for pediatrics is endocrine disorders. Let's talk about congenital hypothyroidism. Not acquired. Remember the most common cause of acquired hypothyroidism, that is going to be your Hashimoto thyroiditis. We are talking about congenital hypothyroidism. The most common cause of congenital hypothyroidism, guys, is thyroid dysgenesis. Okay, that is thyroid dysgenesis. Remember, there is increased risk of short stature if not treated, and also there will be delay in IQ. Okay, there will be reduced IQ. Sorry, there will be reduced IQ. Let's talk about some features which you see in congenital hypothyroidism. Guys, because hypothyroidism is there, so there will be lethargic, dry skin will be there, hypothermia, horse type cry, and delayed passage of meconium. Remember I talked about three conditions. One was anorectal malformation, Hirschsprung disease, and congenital hypothyroidism. If you see the features over here, you will see there will be wide open fontanelle. They will have macroglossia, which is like, big tongue. And remember, very important, they don't have any goiter. They don't have any goiter. Along with that, if you see the abdomen, there is also umbilical hernia. If they'll ask you what are the complications of untreated hypothyroidism, they will be reduced IQ, and also the baby will have short stature. Okay. Last thing is about congenital adrenal hyperplasia. Now, this is the cholesterol synthesis pathway reaching to aldosterone, reaching to testosterone, and this. Many people have different ways of mugging this up, but this is one chart which I used. Okay, and I would recommend you to use this chart also, because there is a very well differentiation of where it is going, what organ it is going, and it is simple mug up. Okay, now it is your choice that you want to do this or a trick. Okay, let's talk about congenital adrenal hyperplasia. Now guys, in congenital adrenal hyperplasia, there are three main enzyme deficiency. The most common type is 21 hydroxylase deficiency. Then second most is 11 beta hydroxylase, and then will be 17 alpha hydroxylase. Okay. Now whenever there is deficiencies as such, there is going to be reduction in testosterone. There can be increase in testosterone. There can be reduction in DP, or there can be increase in BP. Talking about the features, guys. If there is low testosterone in a male, what will happen is there is going to be delayed puberty. If there is low testosterone in a female, no issues. But if there is very, very severely less in male, then there can be ambiguous genitalia. What does that mean is basically the penis gets converted into a clitoris. Okay. If you ask about delayed puberty, guys, in females it is if the secondary sexual characters are not yet developed by 13 years, while in male it is going to be 14 years. Now let's talk about if there is high testosterone. If there is high testosterone in a male, puberty will be much more early. That is known as precocious puberty. Remember, in females it is going to be if it is by 8 years of age in female, and in male if it is going to be by 9 years of age. Now if there is high testosterone in a female, again there will be ambiguous genitalia. That is going to be the clitoris gets converted into a penis, that will be clitoromegaly. Okay. Remember, in such congenital adrenal hyperplasia, guys, you will have hyperpigmentation because of increase in ACTH. Okay, and you will have hypoglycemia because there is decrease of cortisol. Now I just now told you where there is high BP, low BP. It's confusing, and the only way to know is you have to find out in this pathway where there is deficiency or where there is, and then you will find out if there is BP high, BP low, and stuff like that. One way is this. The other way is remember this mnemonic, which is the best thing for you to do. As I told you, there are three common deficiencies: 21, 17, and 11. And we are talking about two factors. One is going to be your blood pressure, and one is going to be your testosterone. What I want you guys to remember in this trick is, wherever the number 1 is there, that side it is going to increase. Any other number than 1, in this case it will be 7 or 2, any other number than 1, that value is going to decrease. I'll tell you what I'm going to say. You're having here 2 digits, right? In each, 11, also 1, 1, 1, 7, 2, 1. The first digit is going to represent, this is the hack, it's going to be representing BP, and the second digit is going to represent testosterone. Okay? And what did I say? Wherever 1 will be there, that value will increase, and wherever any other number than 1 will be, that value will be decreased. Let us apply this hack. Okay? BP and testosterone. So in the condition of 11 beta hydroxylase deficiency, BP will be more, testosterone also will be more. Why? Because both are 1, 1. If there is a deficiency of 17 alpha hydroxylase, BP will be more, but testosterone will be less. Now you understood what I said. Why BP was more? Because there is 1. Any number like 1 is there, everything will increase. Any other number rather than 1, it is going to decrease. So 7 is over here, so that is why testosterone will be low. In 21 deficiency, first is 2. So BP will be low, but testosterone will be high. I hope you understood this trick. And if you guys ever think, okay, what comes first, whether it was BP or testosterone, remember the alphabets. B comes before T. Guys, this is all what I want you guys to know about pediatrics. Just know this videos along with this 5 years of Fmge, 5 years of NEET PG, and 3 years of INI, and you're good to go with pediatrics. Take care. See you guys in the next video. Please remember to read this always before you start your preparation. Take care and see you in the next subject.